Go sit on the bed and watch TV from there. Don't watch it from so close.
ठीक है ओके स्टार्ट कर रहा हूँ स्टार्ट कर दिया
Start कर लो.
Okay, I'm starting. Hi, good afternoon. We are. I'll just give me 2 minutes. I'll just download my lecture and then I'll start. You go and watch your TV.
Okay, but check your WhatsApp. I sent a message. Okay.
Okay, clinical features of tetanus. Clinical features of tetanus. In pathogenesis, the contamination of a wound with spores of Clostridium tetani is probably the frequent occurrence. Contamination of wounds with spores of Clostridium tetani is probably a frequent occurrence. Germination and toxin production, however, takes place only in wounds under anaerobic conditions, such as those with devitalized tissue. Devitalized tissue, foreign body, and active infection. Toxins released in the wound bind to peripheral motor neuron terminals, enters the axon, and is transported to nerve cell body by brainstem and spinal cord by retrograde intraneural transport. Here in picture you can see the parts which can be affected by the disease. The entry of the wound through the skin, then second it spreads the toxins through the blood, Then third, the disease, the lockjaw, cranial and peripheral motor nerve, cardiac failure and respiratory failures leads to that, and then there's a no exit for the wound, no exit for the infection. The toxins act as presynaptic terminals and block release of inhibitory entities and GABA and glycine by cleaving synaptobreviin necessary for export of intracellular vesicles containing neurotransmitters. With diminished inhibition, the resting firing rate of alpha motor neuron increases, producing rigidity and muscle spasm. Loss of inhibition may also affect pre-gangliotic synaptic neurons in the lateral gray matter of spinal cord and produce sympathetic hyperactivity and high circulating catecholamine levels. Now presynaptic calls, here is the synapses and the pathological condition. I think I will skip this. You must have read it in pathology or microbiology. But here, titanospasmin like botulinum toxin may block neurotransmitter release at neuromuscular junction and produce weaknesses or paralysis. Recovery required sprouting of new nerve terminals. In local tetanus, only the nerves supplying the affected muscles are involved. Generalized tetanus occurs when toxin released in the wound enters lymphatics and bloodstream and is spread widely to distant nerve terminals. The blood-brain barrier blocks direct entry into the CNS. Coming to neurotoxins, the motor nerves, and coming to the neurotoxins, the motor nerve, botoxins, muscle fiber, and if it is assumed that intraneural transport are equal for all nerves, short term are affected before long nerves. This fact explains the sequential involvement of nerves of head, trunk, and extremities in generalized tetanus. Now, clinical manifestations of tetanus is the incubation periods varies from 3 to 21 days, usually about 8 days. In neonatal tetanus, symptoms usually appear from 4 to 14 days after birth, averaging about 7 days. Therefore, neonatal tetanus is called as 8 days disease in Punjab. Sorry, 8th day disease of Punjab in Punjab. With a highly toxigenic strain and favorable tissue environment, a large amount of toxins may be produced and absorbed rapidly so that incubation period is short and attack is severe and vice versa. Types of tetanus. The traumatic tetanus is 40 to 50% trauma is the major and the important cause of this type of tetanus. The peripheral tetanus is 5 to 20%. The tetanus follows absorption more frequently than the normal labor, and post-abortal uterus is a favorable site for germination of tetanus spores. Now, otogenic tetanus is 10 to 15%, more common in children. Foreign bodies introduced into the ear may act as the source of infection. Now, idiopathic is 5 to 10%. Maybe the rest may be the result of microscopic trauma due to absorption of tetanus toxin from intestinal tract due to inhibition of tetanus spores. Now, tetanus neonatorum is around 10 to 15%. This is the commonest cause of infection of umbilical stump after birth. High risk group are young persons below 20 years of age, elderly persons above 60 years of age, intravenous drug users, and immigrants. Unregistered antenatal mothers. Now, coming to local tetanus, Middle East form in which rigidity and spasm is limited to the muscle near infected wound. Prodromal illness like malaise, apprehensions, sore throat, mild headache. The first symptom noticed is stiffness of the jaw. Trismus, it may lead to either difficulty on chewing. Or make a patient unable to open his mouth to its full extent with prophylactic antitoxin, and illness does not progress beyond this stage. Rhesus sardonicus, jaw remains tightly closed, muscles of the mouth are tucked towards the upward over the teeth. Eyebrows are hitched from the eye sockets, and forehead is thrown into the deep furrow. Just a minute. I'll just come in a minute.
Remo, I want to be able to see you. Sit in the middle of the bed. Sit on the middle of the bed. I'm not even see you. No, I don't see that.
Sorry. Yeah, so this picture shows the actual tetanus, the jaw, spasm on the jaw. Okay. Generalized tetanus. Here the whole body is involved. Here the whole body is involved with contractions of muscle of trunk, limb, producing actually arched back, leading to the orthotonic position. In severe cases, respiratory muscles are involved, producing asphyxia and cyanosis, and the general symptoms are little headache, abdominal pain or backache, difficulty in passing urine requiring catheterization, and constipation requiring enema treatment. This is the arc-like position. Okay, so neonatal tetanus. In neonatal tetanus, infections results from cord contamination during unsanitary delivery conditions, and children born to inadequately immunized mothers. The baby is normal at birth, but after a few days becomes irritable, faces difficulty in sucking, and develops rigidity with spasm. Prognosis is worse if onset of the symptoms occur within first week of life. Interval between lockjaw and onset of symptom is less than 48 hours. A high fever and tachycardia, spasms of larynx. Okay, this picture shows the. Coming to cephalic tetanus, it is a rare form of disease occasionally occurring with the otitis media, in which clinical tetany is present in the flora of middle ear or following injuries to head. In this involvement of cranial nerve, especially in the facial area of occurs. Okay. Now, Ablett's classification is severity grading. Severity grading is mild, moderate, severe, and very severe. So, in mild, it is mild trismus, generalized spasticity, no respiratory embarrassment, no spasms, no dysphagia. Moderate trismus, rigidity, short spasms, mild dysphagia, moderate respiratory involvement, and respiratory respiratory rate is more than 30. Severe trismus, it is generalized spasticity, prolonged spasm, respiratory rate is more than 40. The severe dysphagia, apnea, spells, pulse is usually more than 120. When very severe, grade 3 with severe autonomic disturbances involving CVS. Coming to complications, the complications are laryngospasm, fracture of spine or long bone, hypertension, hospital-acquired pneumonia, pulmonary embolism, aspiration pneumonia, hyperparexia, and paralytic ileus. Coming to lab diagnosis, it is entirely clinical. The clinic Clostridium tetani is recovered from the wound only in 30% of the cases, and also it can be isolated from patients without tetanus. Demonstration of toxin production in mice is diagnostic for tetanus. Electromyogram may show continuous discharge of motor units and shortening or absence of silent interval, normally seen after an action potential. CSF classification is normal. Muscle enzymes level may be raised. Differential diagnoses are purulent meningitis, status encephalitis, tetany, or strychnine poisoning, or rabies. Differential diagnosis for patients' manifestation only with trismus, which is quinsy, mandibular injury or fracture, temporomandibular joint syndrome, inflammatory conditions of gums and buccal mucosa, dental problems, cervical adenitis, and dystonic drug reactions. Coming to prognosis, severity of the disease. In moderately severe cases of convulsions, less than 2 to 3 times in an hour, the illness is likely to last about a fortnight. In severe cases with convulsion occurring every few minutes, patient rapidly becomes exhausted and dies if not controlled. In fulminating cases with convulsions, almost continuous patient develops respiratory insufficiency and likely to die in a day or two. Okay, now coming to okay, as per the age, prognosis is bad in very young, especially neonates and the very old. It is good in young adults. The incubation period is lesser than incubation period. The lesser the incubation period, the worse will be the prognosis and vice versa. Coming to mortality, case fatality rate is about 40%. The neonates, it is as high as 80%. Yeah, New Year kind of. Anyway, so now we have another lecture. Wait a minute, I'll just go to my next slides. Okay, treatment of tetanus. Okay, the treatment of tetanus and prevention aim is to attack Clostridium tetani in the wound so that it can't produce more toxin. Neutralize the toxin before it can reach nerve cells, and to render the nerve cell less reactive to toxin and muscle less reactive to the impulses coming from nerve cells. Coming to the treatment, either it is general or specific. The general treatment is to stimuli. As stimuli of any kind may participate a convulsion in patient with tetanus noise, the movement must be kept minimal. Specific is wound surgery, antitoxin, and antibiotics. Yeah. Then sedatives, tracheostomy, and curare. Coming to wound surgery, there is a foul contaminated wound. It is logical to explore this surgically. It is logical to explore this surgically in an endeavor to abolish the anaerobic conditions and so prevent the further production of toxin. Antibiotics should be given as soon as possible after the injury before the lethal dose of toxin is produced, that is within 6 hours of injury. A single IM injection, intramuscular injection for long-acting penicillin, that is benzathine penicillin, will be provided. A sustained concentration of drugs for 3 to 4 weeks with sufficient to kill any vegetative form of tetanus bacilli that may emerge from sporulactin stage. For patients sensitive to penicillin, erythromycin is given. The picture is not clear. Okay. Tetanus antitoxins. Once antitoxin is fixed in nerve cells, antitoxin can combine with it or dislodge it. Its effect is to neutralize toxin still being produced and absorbed. Central nervous system is usually severely damaged by toxin before symptoms appear. Antitoxin is this stage may prevent further damage. Tetanospasmin sedation. Tetanospasmin excites nerve cells and produce convulsions. Sedation aims at controlling of convulsions. Tracheostomy ensures the free airway during spasm. In patients who have difficulty in swallowing, spasm of larynx, or other infections with breathing, it is better to go for tracheostomy. Curare and artificial ventilation. Curare and artificial ventilation, tubocurarine paralysis all voluntary muscles and so abolish all convulsions and spasm. Indications are spasm of larynx, spasm of respiratory muscle, failure of sedation. To sum up, the treatment is to prevent more toxin reaching nerve cells by surgery, antibiotics and antitoxin to control the symptoms caused by toxin already inside the nerve cells. Coming to prevention, active immunization. Active immunization is done for tetanus is best prevented by active immunization by tetanus toxoid. Toxoid is the one which is inactive form of toxin with no toxicity but retained antigenicity. It stimulates the production of protective antitoxin. Those are of two types, which is combined vaccine, that is DPT, and monovalent vaccine, a plain form of plain or formal toxin, absorbed toxin, and so on. A combined vaccine is the infant are immunized against tetanus in combination with diphtheria, pertussis as DPT vaccine. According to the National Immunization Schedule, the primary course of immunization consists of 3 doses of DPT, 6, 10 and 14 weeks. The booster at 18 months and at 5 years of age. The third booster TT can be given, but I'm not able to remember the date. Okay, monovalent vaccine. Purified tetanus toxoid has a longer lasting immune response than plain toxoids. Primary course of immunization consists of 3 doses. It must not be allowed to freeze at any time. It is stored between 4 and 10 degrees centigrade. As a passive immunization, which is temporary protection against tetanus, can be provided by injection. Human tetanus hyperimmunoglobulin and anti-tetanus serum. Dose for all ages are 250 to 500 international units. It gives a longer passive protection up to 30 days or more compared with 7 to 10 days for horse antitoxin. Okay. Anti-tetanus serum. If human antitoxin is not available, equine toxin should be used. Standard dose of 1500 international unit uh, injected SC after sensitivity testing. As equine antitoxin is foreign protein, it is rapidly extracted from body, and there may be very little antibody at the end of 2 weeks. ATS gives protection for about 7 to 10 days. The disadvantages of ATS is ATS causes sensitivity reaction in many people. Sensitivity reactions in many people. The person receiving ATS from the first time may tolerate it well, but there is a possibility that subsequent injections of horse serum may lead to allergic reaction. It is not safe to give ATS every time when individual got hurt. Incidence of systemic reaction is 5 to 10% of persons receiving it. ATS stimulates formation of antibodies to it, and hence person receives ATS for the second time rapidly eliminates. Active passive immunization. The purpose of antitoxin is immediate temporary protection. The toxoid is long lasting protection. The prevention of neonatal tetanus. Immunization. Immunization for pregnant women. The neonate achieves natural passive immunity from mother against tetanus. Administration of toxoid to pregnant woman. Formation of antitoxin. An antitoxin enters the fetal circulation through placenta. Government of India launched EPI in 1978. The objective was to reduce mortality and morbidity resulting from vaccine preventable disease for childhood. The vital components are immunization of pregnant women against tetanus by 100% coverage of pregnant women with 2 doses of tetanus. The immunization of children in their first year of life against 6 EPI diseases, which is 85% of coverage of infants with 3 doses of DPT, OPV, and first dose of BCG and measles by 1990. The tetanus toxoid will protect both mother and child. The immunized pregnant woman with 2 doses of tetanus toxoid. The previously immunized pregnant woman only one booster dose. If there is a previously immunized pregnant woman, only one booster dose is necessarily needed. As part of national immunization schedule, these doses are to be given between 16 to 36 weeks of pregnancy, with the interval of 1 to 2 months between the two doses. No pregnant woman should be denied even one dose of TT if she is in the late pregnancy. Training of traditional birth attendants. The training of local DICE if one of the function of primary health care as one of the function of primary health center. The extensive program has been undertaken under the Rural Health Scheme to train local DICE to improve their knowledge in the elementary concepts of maternal and child health and sanitization. During the train, emphasis is laid on asepsis so that home deliveries are conducted under safe hygienic conditions. Training of traditional birth attendants alone can reduce death due to neonatal tetanus by 90%. Birth attendants are provided with home delivery kits. They should be educated about five cleans: clean hand, clean delivery surface, clean cords, clean blade for cutting, clean ties, and avoid application of cord stuff. Infants born with mother who are not immunized with tetanus toxide are at risk of tetanus. They are protected by injections of antitoxin 750 international unit if it is administered within 6 hours after birth. The prevention of tetanus after injury. All all wounds must be all wounds must be thoroughly cleaned soon. After injury removal of foreign bodies, soil with abolish aerobic conditions. In order to achieve early elimination of neonatal tetanus, ICMR has achieved that effort should be made to cover all women in reproductive age group with 3 doses of tetanus toxide vaccine through a campaign approach. Immunization against tetanus is achieved through universal immunization program, which become a part of CSSM program in 1992 and RCH program in 1997. Thank you. I think we covered clinical features as well as treatment and prevention, and we finished this tetanus toxide tetanus tetanus toxide lecture and the chapter, and then we'll continue with next chapter, probably leprosy tomorrow. Okay, have a good day. Goodbye.